Thank you, Rose, and I'm delighted to be here. And since we're doing confessions, I wasn't trained in medicine. As a matter of fact, I was trained in medieval studies. So if you want to talk about confusing, you should see the look on people's faces. That's the story for another day of how I got here. But today I'm going to talk about one of my favorite topics, which is how we really involve patients and families across the continuum, specifically how we'll do that in medical psychiatry. And we've heard some interesting sort of little snippets throughout the day already around how we involve patients. And we heard Mary Jane say she learned some of what she knows from patients in oncology rotations. And so what I want to do is talk a little bit about some of the approaches, and I'll give you a few snapshots of things that we can think about as we move forward. All right. So does anybody know what this is? I see some nodding heads. This is a glacier, and this is Marjorie. And Marjorie lives in Alaska, but like all good things, starts in Canada. It's 35 kilometers long, starts at Mount Root. And yesterday I said to my wife, I said, I'm doing a talk on patient involvement, and I need a picture of the glacier. And she gives me the look that she normally gives me, like, what are you talking about? And she said, so what does this have to do with patient involvement? So I have 4 things that I want you to keep in mind about Marjorie that I think are helpful in terms of patient involvement as we go along. So first of all, this is a spectacular site, but it's very hard to get to. So most people want to go to see Marjorie, but in order to get there, you either have to go by plane or you'll go on one of those large cruise ships and you pull up next to it and you sort of get a glimpse. But very few people actually get the opportunity to be really involved with this particular glacier, which is quite interesting. The second thing that I learned about Marjorie is that it's not just one glacier. So glaciers are made up of streams, and they all come together over years. And so when you talk about a glacier, you're actually not talking about one thing. You're actually talking about something with very complex layers. The third thing is that glaciers like Marjorie transform the landscape. Once they've been there, the place looks completely different. And the fourth thing is that you can understand it from, the point of view of, which is common these days to talk about glaciers in terms of how fast they're receding, but they're actually very complex to understand. And not only do you have to understand the science behind them, but you have to understand the cultural context. So in the 1800s, there was a mini ice age, and Marjorie and other glaciers receded and drove out an entire indigenous population out of this area. And so if you want to understand the history of this area, you have to understand what it did to the peoples that it displaced, as well as how fast it's receding and what its impact is on the environment. So a few ideas that we'll see if we can carry forward. So I said that all good things come from Canada. This is an engagement framework that's quite important, and I don't know where Sean is, but this comes from the UK. So, okay, I lied a little bit. But that's okay, we can borrow good things. And this is an engagement strategy that the NHS in the UK adopted several years ago, trying to think about where are the areas that we should involve patients. And actually, their framework that they came up with was very simple. Everywhere. And so how do we go about doing that? And so they developed this framework that said, hey, look, there's a role in strategic planning and engaging communities to identify needs, engaging the public in decisions about what the priorities should be. So that's the orange area. In red, they said, in specifying the outcomes, let's think about what the outcomes should be, and engaging patients in helping to define what the outcomes should be. And then managing demand and performance. And so to go back to the theme of simulation, how do we involve patients and their families in helping us determine what our performance should look like? And in order to think about this, over the years, I've found that the empowerment model is quite useful as I've been doing engagement and involvement work. And so there are three sort of main components, and a lot of people really focus on the individual and thinking about how do we help enable individuals to get involved. And so obviously there are things like self-efficacy and the idea of confidence in the knowledge that's required. But really that's just part of the problem. Making sure that you have an organization that will function in such a way that will enable individuals to be involved is key, and then that needs to continue to where most of the care happens, which is in the community. To illustrate this, a friend of mine who passed away a couple of years ago, might be well known to several of you in the room, Dr. Kevin Leonard, was a great advocate for patient involvement and patient access to the health records. And he used to tell this story. He had Crohn's disease, which he was very open about, wrote a book about. And he used to talk about how he could never get access to his own information. It became his crusade. And so one day he went for an ultrasound, and he was on his way to the physician afterwards to see it for an appointment. And he asked, because he always did, he asked for a copy of his record, and he was going to show it, the test results, to his physician. And the person who was doing the ultrasound said, right, no problem, took the piece of paper with the results on it, folded it in half, got out the stapler and stapled all around the piece of paper and handed it to Kevin. And Kevin looked at the person and said, what do you want me to do with this? Do you think I'm hard of removing staples? Like, what's going on? And I think for me, that's an example of how you can empower an individual. But unless we have a whole conversation, you can quickly dissuade people from using that power. And as we're thinking about frameworks, this is the chronic care model, which is often used to think about how we develop systems that will deal with chronic disease. And what I want you to focus on is that bottom quadrant, which is how do we, really create productive interactions. And there are really two ingredients here. That's the informed, activated patient and the prepared, proactive practice team. And how do we really enable both of those groups to work together? That's a question for all of us and some of the work that we're trying to do. And hopefully all of that together with the right systems will lead to improved outcomes. So at the Center for Addiction and Mental Health, we've been thinking about how we develop a client and family education program, and we've taken some of these ideas, putting the clients and families and the health professionals at the center, trying to think about how we create that productive interaction. We've taken a recovery model approach to this, and so some of our values are that around that second ring, which are around hope and optimism, around a sense of connectedness, a sense of a sense of being enabled to act and an empowerment, and then knowledge and reflection on learning. And then around the outside are some of the components that we put together, and I'll talk about a few of these as we move along. But client and family as teacher is one pillar of our program, looking at how we can use technology, how we do research and knowledge generation through this, how we reach into the community, how we provide information tools and support to our patients and our families, and how do we put the right systems in place. So in 1982, the WHO published this particular paper, which is around the therapeutic value of patient education, and created a whole model, which unfortunately hasn't really been widely adopted. But the findings of that time, and we've progressed a lot, but these findings I don't think have changed very much, which is in order to really have the effect that we want to, we need to really focus on behaviorally oriented programs, and with a special attention to changing environment. And that's what I want to focus on a little bit today. So as we were developing our program, we did a very large literature search looking at specifically, what are some of the programs in place for recovery-oriented patient education? And this was the work of a large team. I had done this work in cancer care in the past, and one of the very interesting things I saw right away was that Canada wasn't really a large player in this field, especially in mental health. And if you did this, as I've done for cancer care, Canada has a huge role to play. And so we have some catch up to do with the rest of the world here, which I think is important. Some of the things that we found is that most of the programs really focused on mental illness and on disorders, and there wasn't as much on the knowledge and the skill building as we would have expected. Most of this work was happening within the hospitals, and the majority of this work was focusing on outpatients. So 77% was really focused on the patients themselves and the recovery, less than 20% on families, which is an interesting observation, something to think about, and less than 5% was focused on healthcare professionals. So if you think back to that model that I showed you, informed patient, prepared professional, the literature certainly isn't reflecting that there's a sort of equal balance in getting people prepared. We took some of that work and we really wanted to focus on outcomes. So we looked at all of those papers and we were able to determine 732 outcome domains that people were measuring. And we applied this to a Kirkpatrick framework. And, you know, I won't get into the specifics of this, but of those over 700 outcomes, the majority, so 72%, were focused on the really outcome side. And again, if you compare this work to what's happening in, for example, cancer care, it's actually the mirror image. In the cancer care, you'd see a lot more around the satisfaction, the learning, and the behavior change. And that's really changing and it's shifting. But my point here is that we probably need to be somewhere in the middle, not just focusing on the outcomes, but focusing on the process and how we get there. So one of the programs that we've been trying to develop is clients as teachers. And I have to say, much like the glacier, much like Marjorie, there's a long history here. There's kilometers and kilometers of work that's been done, and a lot of studies and a lot of pilot studies. And one of the things that we're trying to do, though, is shift to this becoming a norm. So the question isn't how do we do another pilot study? The question is how do we develop a program where we can push this forward? And so even William Osler, back in 1904, had this quote, and the language is a little outdated, and I apologize for that. But you know, this quote I think is important. It is a safe rule to have no teaching without a patient for a text, and the best teaching is that taught by the patient himself or herself. So this is an idea that we want to take to a programmatic level and think about how every educational intervention we might embed this. So Angela Towell, who's out in UBC, has created this level of engagement. And just a plug for Angela, in 2 weeks, she's going to be hosting the second international Where's the Patient Voice in Health Professions Education. The first one was 10 years ago, so talk about slow moving. But it's a group of very committed people. You know, sort of level one starts where you'd expect, with engaging patients to consult. What should we be doing? What should the process look like? Move up a level to inviting people to be involved in some evaluation, some practice exams. Then we go up a little bit again on the scale and getting people to tell their stories and tell their experiences. And again, this goes back to the text as teaching. And then even moving forward, we can talk about things like how do we start to give patients and their families a role in teaching? What does that role look like? How do we manage that? How do we start to think about their role in terms of evaluation? And finally, how do they start to drive where we should be going? So these are some of the tough questions that we have to ask ourselves as we move forward. As I said, there's actually quite a large body of literature. And last year, there was a systematic review that came out specifically looking at mental health issues, for example, which I thought was interesting. One of the findings of this study was that the majority of work was actually happening in nursing, and probably not a surprise to the nurses in the room. But again, thinking about where's the balance in the system. Students generally saw the benefit of the interaction, but one of the findings of this study was that across the board, students, teachers, and the clients as teachers weren't getting enough preparation. There wasn't enough work happening to actually prepare people. What was going to happen when they went into their room? A lot of people getting thrown into situations and having to deal with that. We've got a lot of initiatives going on at CAMH, and we're looking at a number of ways to move to a program. So Sean Kidd has developed a speaker series where clients are brought onto the ward. Sasha Agrawal is leading a project where service users are becoming advisors to medical residents. We are now developing a competency-based program to help service users to actually step into the classroom. What does that look like? Some other things as well. This is really about changing the paradigm and changing the way education looks. So embedding service users throughout and thinking about what that means within the classroom, within direct observation, indirect supervision, and mentoring. How do we change this shape of education moving forward? And how do we think about this in a creative way? I'm not going to show this video, but this is a video that Sean Kidd did, trying to do some knowledge translation around his work of bringing clients into the ward. And so they created this 20-minute video, and the scenario is that a patient and a nurse are having a bad day. They have several bad interactions at the end of the day. They both are in a rush to leave the building, and they get caught in an elevator together. And the nurse has a panic attack, and the patient helps the nurse through the panic attack. And it's about working through that situation. Just one last project. Sanjeev has given me the signal of a final minute. I'll just give you 2 seconds about ThoughtSpot. Marcus Law, who you'll meet in a second, is the principal investigator on this particular project. And the Ministry of Training Colleges and Universities came up with a call a few years ago, and they said, we want some solutions to improve student mental health. We came up with this idea of a student-driven project, and it was quite simple. We were going to use crowdsourcing to help students guide other students to access mental health services. And when I asked the team, what are we going to do? How are we going to make this happen? They said, we don't know. We're going to ask the students. And so we did, and we held a hackathon, which we called Hackathon. We invited over 60 students to participate in this. They formed 14 teams. And for our site ThoughtSpot, they came up with mobile solutions, which the student jury selected one of them, and we've now turned that into the ThoughtSpot mobile app. So just a few final thoughts. So really, I hope you got from this brief passing past the glacier that we really want to take a systems approach to this, not just another pilot project, but really a programmatic approach, that we need to change the paradigm to co-creation, and we need to reimagine the environment. And just the one takeaway, we're all teachers and we're all learners. Thank you.